Hi, everyone. I'm Dr. Faisel Syed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel Friends, where we believe access to primary care is a right, not a privilege.
Today, Faisal and I are investigating what can primary care do for COVID. Let's dive right in.
Hi, Dr. Dan.
Hey, Faisal, it's good to be with you.
It's good to be back on again. I've read just in the last couple of weeks about how rural counties had more than 2 or 2.5 times the mortality with COVID compared to more urban counties. And the reason why is because of low vaccination rates. And it's interesting because also during these last few weeks, when we're meeting residents again in person. And one of the points that comes up pretty often is, well, hey, what could primary care do to improve COVID, the outcomes with COVID?
Right, right. Yeah, it's interesting. I got asked that question in New York City about 2 weeks ago. And when you think about it, when COVID started, especially, it was primarily about supporting the patient. There weren't any proven treatments. I mean, there were a lot of things that have now been debunked as potential treatments, but there weren't any proven treatments. And so working with people to help them protect themselves and giving good advice would seem to make a difference. But yeah, that's really wild because when you think about it, in rural areas, people should have been more physically distant. So they should have been at lower risk rather than higher risk.
But then that's what it comes down to. When we compartmentalize and we say, well, you know, prevention, vaccines, that kind of falls under the public health umbrella. That's a public health box, and that's not the concern of primary care. And the residents are being trained to focus on the chief complaint. Like there has to be something that starts the engagement, and then they got to react to that engagement. There's no incentive to look ahead of it, and then also if you look at like what drives the hesitancy in general with people getting vaccinated or taking the advice of doctors with doing the right thing or doing safer things, not even the right thing. I think it's a system. We don't have a system where the patients feel comfortable to trust the advice from the ones who should know them best.
Well, and you know, unfortunately, the concern, especially in rural areas, is people don't have access to a primary care physician to have that relationship. I mean, I I forgot he was talking something about COVID. It was Aaron Carroll, one of the columnists in the New York Times, who's also a pediatrician, but he was talking about what we're going to learn about the US healthcare system. And one of the points in the article was that less than 50% of the US population has access to a primary care doctor that they can call about a problem and be seen that the same day or the next day. And it makes a huge difference if people aren't available. So they don't. We've talked many times that there's not a CPT code for a close doctor patient relationship, and so there is no financial incentive in the fee for service world to build those relationships so that they will call the doctor to be the source of truth, and there is no financial incentive for the doctor to pick up that phone call and answer that phone call. So now people are left with Dr. Google or Dr. Bing or Dr. DuckDuckGo or whoever their search engine of choice is, and the issue. Not I certainly use the internet a lot as well, but I once heard somebody say that getting medical information out of the internet is like drinking water out of a fire hose, and you don't really know the quality of the water source coming out of the fire hose. And so you have to be able to evaluate the quality of the evidence, and it's very hard to do.
especially early on in the pandemic. Remember when it was, oh well, this is a horrible cold. It's going to feel like a terrible cold, or this is like a horrible flu-like disease or flu-like illness. So then you don't, the risk wasn't there. Like the feeling of the risk wasn't there. That hey, well, the risk this is pretty low. That we don't really we don't really need to follow the safety advice because or the prevention advice because even if I did get this thing, from what I'm reading online, whatever I'm seeing on my social media or whatever I'm searching online, and if you don't have access to a doctor or to a primary care delivery team or medical delivery team, then hey, the risk is low to me. I'm gonna kind of sit and wait. And we didn't sit and wait. I remember in March, we were in March 2020 when we made such big changes, drastic changes across the country. Most people were still kind of wait and see kind of approach.
Well, and I think if you look at it, I think a lot of people said they were surprised that we had a pandemic. I think everybody who's been to medical school and has taken an epidemiology course knew it was going to happen sometime. But honestly, we have sort of dodged a couple of bullets. I mean, it was before our time practicing medicine, but back in the 1970s, there was the swine flu. And, that was a time that vaccines were rushed and they got them out. And there were more complications from the vaccines than there were from the flu. And then back in when was it? It was sort of the 2010s, the H1N1 pandemic. I don't remember the exact date, but everybody sort of rushed to get ready for it. We heard there was this disease, it was in Mexico, it was killing all these children, and we had to be ready for this wave. And yeah, it came and it was fairly contagious, but it wasn't nearly as lethal as anybody thought. And we didn't wind up swamping the hospitals or anything like that. So I think when this one came, everybody was like, well, it, none of the other ones have really played out the way they were going to play out. So this one might not. And this turned out to be the real deal, obviously. And I think that especially, public health has been especially hard hit. I mean, funding had been cut for public health, and rural areas especially have had trouble attracting physicians to run the health departments in the rural areas. So there's probably a double whammy in the rural areas. They had less resources in public health and less resources in primary care, and therefore they were especially reliant on Dr. Google to be getting their medical information.
The ultimate underserved, right? They didn't have the access, and they were having to rely on unreliable sources for issues involving any kind of prevention. When you're talking about prevention or trying to overcome prevention hesitancy, and it could be with vaccines, it could be with whatever diabetes, heart disease. If you're talking about prevention, then is it if the priority of the prevention is low, then everything else is much more of a priority than that. There are many other situations going on with underserved populations that are much more important to people than the prevention, especially if the thought is or the feeling is the thing that these medical people are trying to prevent. It's the risk over there is low.
Right.
And then we in the medical, if we know this about hesitancy in general, there's nothing new about hesitancy, then I think we can do a better job with the language. We can do the better job with the language. You know how in our model, language matters so much. We don't an unscheduled patient visit. If a patient shows up unscheduled, we don't refer to them as a walk-in. I think that language, there's something about that language. The front desk person brings a patient to the back saying, "Oh, we've got a walk-in." People's reactions or tendency when you have a negative, you kind of roll your eyes and think, "Oh, here's this walk-in who's an inconvenience to my schedule." But when you call them, we call them patients in need. The patient is in need of medical attention. Then the reaction to that is very different from the clinical staff. Hey, I have a front desk staff brings a patient in need. Say, I have a patient in need. Then everyone suddenly remembers why they went into medicine or healthcare in the first place.